Ankylosing spondylitis. What is ankylosing spondylitis? It is characterized by a chronic inflammatory arthritis predominantly affecting the sacroiliac joints and spine, which can progress to bony fusion of the spine. Clinical features are age. The onset is typically between the age of 20 and 30 years. Male predominance is seen and male is to female ratio is 3:1. Spinal features which are usually insidious are inflammatory low back pain, then early morning stiffness is present, and as the disease progresses, the spine becomes increasingly rigid as ankylosis occurs. Secondary osteoporosis predisposed to vertebral fracture. The physical signs are restriction of the movement of the lumbar spine in all directions. Pain is felt on sacroiliac stressing. As the disease progresses, stiffness increases throughout the spine and the chest expansion frequently becomes restricted. A few patients develop marked kyphosis of dorsal and cervical spines. There is failure to obliterate the lumbar lordosis on forward flexion, which is called Schober's test, and it becomes positive. The extraspinal features are pleuritic chest pain, which results from involvement of costovertebral joint, then enthesitis, which means the inflammation of enthesis, the site where tendons insert into the bone, and peripheral arthritis is seen in up to 40% cases. This is usually asymmetrical, affecting the large joints such as hips, knees, ankles, and shoulder. The extra-articular features are rare except ocular involvement, which occasionally precedes joint disease. These extra-articular features are anterior uveitis in 25% of cases and conjunctivitis 20% cases. Prostatitis in 80% men, which is usually asymptomatic. Cardiovascular disease such as aortic incompetence, mitral incompetence, cardiac conduction defects, and pericarditis. Atypical upper lobe pulmonary fibrosis is seen and amyloidosis is seen. The investigations include ESR and CRP, which is raised, rheumatoid arthritis factor or RA factor is negative, HLA-B27 is positive, and X-ray shows the radiological signs of ankylosing spondylitis such as sacroiliac joints are seen to be fused, which occurs in both sacroiliac joints. Lateral thoracolumbar spine, typical bamboo spine is seen, which is featured by bridging syndesmophytes, squaring of vertebral bodies, and ossification of the anterior longitudinal ligament. MRI of affected joint is more sensitive than X-ray to detect early sacroiliitis and inflammatory treatment. The aims of management are to relieve pain and stiffness and maintain a maximal range of skeletal mobility and avoid the development of deformities. Firstly, we have to give education to the patient, then appropriate physical activity such as exercise, daily back extension exercises, swimming, cycling should be done. Then avoidance of prolonged period of inactivity, for example driving, computer work should be done. Then poor posture should be avoided. Drugs should be used such as long-acting NSAIDs at night to reduce morning stiffness. Anti-TNF or anti-IL-17A therapy should be considered in patients who are inadequately controlled on standard therapy. Local corticosteroid injections for persistent plantar fasciitis and other enthesopathies. Oral steroids occasionally for acute uveitis but should otherwise be avoided. Then surgery is done. A severe hip, knee or shoulder restriction may require surgery. Arthritis and ankylosing spondylitis. In rheumatoid arthritis, the age of onset is third to fifth decade, where in ankylosing spondylitis, the age of onset is second and third decade. In rheumatoid arthritis, male and female ratio is 1:3, and in ankylosing spondylitis, the male is to female ratio is 3:1. In rheumatoid arthritis, there is symmetric polyarthritis, but in case of ankylosing spondylitis, there is asymmetric oligoarthritis. In rheumatoid arthritis, small joints of hands, feet, and wrists are involved, but in ankylosing spondylitis, axial joints are involved. In rheumatoid arthritis, hand joint involvement is present, but it is absent in ankylosing spondylitis. In rheumatoid arthritis, there is no family history, but in ankylosing spondylitis, there is tendency for familial aggregation. In rheumatoid arthritis, rheumatoid nodule is present, but in ankylosing spondylitis, this rheumatoid nodule is absent. In rheumatoid arthritis, deformity is present in hand joint, especially which is manifested by Z deformity, ulnar deviation, and swan neck deformity. But but in ankylosing spondylitis, the deformity is mainly in spine.